Hello, everybody. Welcome back. This is the Science Dispatch Podcast. I'm Cameron English. That is Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, so good to be with you again.
It's so nice to be here. It's a very balmy day here in the Northeast. We're approaching 10 degrees. I'm thinking of switching over to my shorts.
Yeah, you're going to get that back sweat pretty soon if you're not careful.
Oh, yeah.
Okay. Another story to discuss. This is by our mysterious contributor, Dr. Y. I believe he's an expert in nuclear medicine. Is that right, Chuck? Is that where
he is? He is.
Okay. Dr. Y, his professional commitments require him to write pseudonymously for us. But his article is called 28 Mornings in the Basement, A Patient's View of Cancer Radiation. Here's the overview, Chuck, and then let's talk about the specifics. So, the good doctor writes, radiation therapy is often described in clinical terms, but rarely through the eyes of the person lying on the treatment table. After decades of working with medical radiation professionally, I found myself on the receiving end of the beam. This is what radiation therapy looks and feels like. Interesting setup for an article, Dr. Dinnerstein. So fill in some of the details.
I empathize with it because, having retired from clinical surgery, I find myself on the other side of the desk and very frequently, unfortunately of late, laying on the table versus standing next to the table. So I have empathy for Dr. Y's situation. He talks about having had an elevation of his prostate-specific antigen, PSA, and following it for several years with watchful waiting. And I think that's when he makes his first important point, which is that watchful waiting involves a lot of action and is really very little watchful at all. And it is a way to avoid intervention, but it does require annual PSAs, which are blood tests. And as that PSA rises, it leads to frequent biopsies. And I think he mentions that he was biopsied on several occasions, searching for tumor, and that our techniques for doing that have improved greatly over the years. Instead of doing blind biopsies now, the biopsies can be performed using an ultrasound in the office to image the prostate and take biopsies of suspicious areas, or by doing MR imaging and doing guided biopsies on that basis. Once the biopsy turns out to be a cancer, that opens up the question of treatment. And I know very few people at this point, when told they have cancer, elect to continue to watch it. So the options really come down to surgical intervention or radiotherapy. The overall results with both are excellent when the tumor is caught early, which means that it basically is confined to the prostate itself. But the treatment and the subsequent side effects are what really separates the two. So let me just talk about the surgery for a moment, which is called a radical prostatectomy, where the prostate is taken out. And that involves, at this point in time, outpatient surgery in some cases. In other cases, an overnight stay in the hospital. It involves having a catheter in your bladder for a week while the reconstruction heals. That's probably what most men find most annoying about the early pre-operative or post-operative period. The downside long-term is that there's a number of nerves that control continence as well as erectile function that pass through the area of the prostate and can be caught up in the tumor and can be caught up in the surgery. So there is a defined incidence of both incontinence and erectile problems subsequent to surgery. So most men who are sexually active are going to be disinclined to think about a surgical treatment. Surgery has gotten significantly better during my clinical lifetime. it's gone from an 8-hour operation and a week in the hospital to about a 3-hour operation and an 8-hour stay at the hospital. So that's been big. Dr. Y goes and chooses instead to go with radiotherapy. And I'm sure everybody has heard this advertised on television as CyberKnife or various versions of it. Traditional radiotherapy involves treatment every day for 9 weeks. There is a variation, CyberKnife, which is a higher, more intense beam that's given to you for over the course of a week. Again, the results in terms of final outcome is essentially the same between the two. So it's oftentimes a patient convenience more than anything else. And Dr. Y goes on to describe going in every morning and taking a ride into the city, going into his radiotherapy center and spending 10-15 minutes in a machine that does all the work. There is a physician who calculates the dose to be prescribed to the various portions of the prostate. That's loaded into a machine, and it's all driven by a computer ever after. And he goes on to describe that. What I thought was interesting was not so much the daily grind of going in and out and getting on with your day, but the subsequent problems that he had early on. And that's not discussed as frequently, but radiation causes what you can think of as a slow burn, and it's a burn that continues forevermore. So that as a result, those same nerves that you were concerned about with surgery are not cut, so you don't lose continence or you don't lose erectile function, but it does over time cause chronic inflammation to them, so they act in a different way. The phrase I would use is radiation therapy can cause rectal ambiguity. You're really not sure whether it's going to be a fart or not coming out.
I'm sure there's lots of studies in the medical literature on this particular phenomenon.
I haven't seen that phrase used a lot. Shart comes to mind. Combination of term. So, I think that there was the inference there from Dr. Y that might have been part of the issue going forward. Having said all of that, prostate cancer is probably at this point the most common cancer among men. It is rarely a cancer that men die from.
I'm grateful for that. That's good. That's certainly good.
There is, and as with everything else, there is a genetic component to it. People with a BRCA gene, like women that have a BRCA gene, are more likely to develop breast cancer. Men with a BRCA gene are also more likely to develop prostate cancer. But we've made a lot of progress over time. We're no longer doing prostate digital examinations, that great homophobic bugaboo for people. It's a blood test, and it's certainly worthwhile to do it on a annual, semi-annual basis based on your age and your family history.
Very good. Practical advice, which is good to get from doctors instead of people on the internet warning you about food dyes and other such silliness. Go check out this article. Chuck, this is reminiscent of your recent piece on your experience with cancer, which is good. It's always good for people to get the insider's perspective from someone who knows how to treat these conditions. It just adds a depth of analysis that I think is really helpful. So everyone go check this out. Once again, it's called 28 Mornings in the Basement, A Patient's View of Cancer Radiation. That is by Dr. Y. That is at acsh.org. When you're there, click the subscribe tab. Give us your email address. We'll send you the stories we publish. The ones you read, usually the ones we talk about. We're on X at acsh.org. We're on Facebook and YouTube, ACSH Matter of Facts. We're also on Instagram. Go follow us. Thank you as always. We'll see you next time.